Hello, everyone. Welcome to Nova Southeastern University's South Florida Geriatrics Workforce Enhancement Program podcast, also known as the SF-GWEP podcast. We're here to educate, encourage, and enhance our knowledge and skills and promote all those amazing health professions experts working with the elderly, including caregivers and interprofessional teams. My name is Naushira Pandya, and I'm professor and chair of the Department of Geriatrics at Kiran C. Patel College of Osteopathic Medicine at Nova Southeastern University, as well as the project director for the South Florida Geriatrics Workforce Enhancement Program. In today's episode, we'll discuss the important topic of Alzheimer's disease, current research and treatment options with our special guest, Dr. Marc Agronin. Dr. Agronin is a leading geriatric psychiatrist and the acclaimed author of How We Age, A Doctor's Journey into the Heart of Growing Old. He has been published in the New York Times and regularly writes on aging and retirement issues for the Wall Street Journal. He holds a Bachelor of Arts in Psychology and Philosophy from Harvard University and obtained his Doctor of Medicine degree from the Yale School of Medicine. He completed his residency training in psychiatry at Harvard Medical School and a fellowship in geriatric psychiatry at the VA Medical Center in Minneapolis, Minnesota. Dr. Agronin is a distinguished fellow of the American Psychiatric Association and past president of the American Association for Geriatric Psychiatry. He is also an affiliate associate professor of psychiatry and neurology at the University of Miami Miller School of Medicine and has received the Excellence in Research and Education Award by Leading Age. His work is dedicated to improving the lives of older adults through advanced clinical research and memory care. He has pioneered a new way of thinking about aging as the next phase of a long and purposeful life. Good morning, Dr. Agronin. It's a pleasure to welcome you to our SF-GWEP podcast, and I'd like to start by thanking you for your time and expertise.
It's an honor to be on the program, and I thank you for the invitation.
So, in general terms, can you tell us why the topic of Alzheimer's disease and following that geriatric mental health overall is so important to you?
Well, I would say, first of all, it's become important to our society in general, largely because of demographic trends. The number of individuals 65 and above is increasing tremendously. It's predicted to nearly double within the next 25 years. And because aging is the main risk factor for Alzheimer's disease, this is why we see so many more individuals with this disease. In fact, this affects well over 6 million Americans, and this number will double in the next 25 years.
Indeed.
Everyone is affected by this without question. Now, as a geriatric psychiatrist, I've always worked with individuals with Alzheimer's disease. And so the relevance of it, the importance of it has not changed at all across my career. I will say there's been a lot of shifts that we can talk about in terms of who I'm working with, what we can do with them. But for me, also, it's a very personal issue because I've always been interested and dedicated to working with aging individuals across the spectrum of mental health issues and neurocognitive issues. And seeing so many individuals who are living with neurocognitive changes brings home to me the importance of doing everything possible to help them.
I remember our days back when we worked together at the State Veterans Nursing Home, and you provided geriatric psychiatry consultation, and I remember you had a particular affinity for the aging veteran population.
I have loved working in the VA systems. I did some of my training there. I worked at the VA Medical Center in Minneapolis, where I did my geriatric psychiatry fellowship. To me, it's a really special honor working with aging veterans. What they've given for our country, what they've given to our world is so extraordinary. And in particular, I really had a fondness for working with the World War II veterans, a group that's shrinking by the day. Uh,
Yes.
my biggest influence in my life was my grandfather, who was a general practitioner in a small town of Wisconsin, and he was a World War II veteran. He served in the Army Air Corps in the South Pacific during the war. And in
I
fact,
see.
I had the really distinct honor of working with a number of veterans who were in the same location in the same era when he was there. And for all I know, he could have been one of the doctors for them. So Yeah, the VA system really needs all our support without question.
Thank you. As we see the rise of Alzheimer's disease and other related dementias in the geriatric population, can you talk a bit about the current research on the origins of the disease and the factors that play a role in developing Alzheimer's disease?
There's been a tremendous increase in research over the past 25 years, and this has brought a significant increase in our understanding of Alzheimer's disease, even though we know that our theory today might not be the theory we have in 10 or 15 years from now. But essentially, what we've learned is that, from the very beginning of the description of this disease, from Dr. Alois Alzheimer himself,
Yes.
that if you look inside someone's brain with this disease, you see two major pathological hallmarks. One, you see these plaques of a toxic protein that we now know is called beta amyloid that's outside of neurons and spreads throughout the brain. We also see inside neurons what Alzheimer described as these hair-like tangles. We now know those are composed of a destabilized form of tau protein. And so knowing the story of amyloid and tau over time has given us the best window into understanding the genesis of the disease, both its genetics, how it damages nerve cells themselves, and the brain architecture in general. Two big changes have been, number one, being able to identify these proteins without having to do a brain biopsy. So this allows us to have what we call biomarkers or physical indicators of the disease through PET scans, analysis of cerebrospinal fluid, now even plasma tests that we can do. That's made all the difference. It's given us a better sense for when people are more at risk for this, even if they're not symptomatic. It allows us to track the disease, or at least its pathology, over time. And it's also opened up avenues for treatment, as we'll talk about, which have really been a game changer in the past few years.
Yes, it's been exciting, and I think clinicians will need to get up to speed on the biomarkers that are available and non invasive testing that we can do. Of course, spinal taps are not non invasive, but I think we're getting to the stage of identifying plasma biomarkers and, of course, specific imaging tests.
Yeah, I know in our memory center now, one of the first things that we will do is a plasma biomarker test. So it's a blood sample. We can look at levels of beta amyloid and tau in the blood. It's not the gold standard yet, but I imagine within a few years, as we gather more data and refine our tests, that these will become more the gold standards, as opposed to having to do a PET scan or a spinal tap, which, you're right, is invasive. Having earlier, easier diagnosis is critically important, especially as we begin to match this up with new treatments.
Before we talk about specific treatments and the newer agents that are being released, have the risk factors for Alzheimer's in and of themselves changed at all?
The genetic risk factors have always been there, but we've gotten a deeper understanding of what they mean and their implications for the course of the disease. I would say some of the most exciting research in the past few years has been looking at modifiable risk factors. In fact, it's estimated
Yes.
today that roughly 40% of all cases of Alzheimer's disease can potentially be prevented by addressing modifiable risk factors. And we've begun to appreciate better what those are. Certainly, something like aging and genetics cannot be modified, but
No.
if you look at things like physical activity, obesity, tobacco and alcohol use, diabetes, high blood pressure, chronic depression, hearing loss, these are amongst a number of risk factors that we can modify. And so, in fact, what we've started an initiative is to have an Alzheimer's prevention program. So individuals who are concerned about brain health or concerned about a family history can come in and have a full assessment of all their risk factors, with some coaching then to follow on how to modify those that can be modified, with the goal of reducing their risk, potentially even preventing the disease in the first place.
Yes.
And once people have a diagnosis, we know that a brain healthy lifestyle can promote wellness, potentially can slow down the course of it. These are things we still need to better understand, but we're being more aggressive with promoting brain healthy lifestyles, especially relevant to what I mentioned before. If we can diagnose individuals in the very early stages, or even determine that they're at risk for it, then
Yes.
lifestyle factors can have a greater impact.
Yeah, because In this country, mortality due to Alzheimer's disease is still high. We're doing better with cancer, stroke, cardiovascular disease mortality, but we're not doing that well with Alzheimer's disease. And in my clinical world, I am very mindful that even midlife control of hypertension and adequate control of diabetes, avoidance of frequent hypoglycemia is very important in working towards preventing cognitive impairment.
It's very true. We have to add on, in addition to all the other factors we look at for health, high blood pressure, glucose levels, cholesterol levels. We need to add in some sort of brain assessment because you're right. The roots of any form of neurocognitive disease, whether it's Alzheimer's disease or vascular dementia or any of, lies decades before we actually get symptoms for many
Yes.
individuals. And so if we can intervene and head off some of these blows to the brain early on, absolutely it will make a difference.
Yes, very well put. And the thing is, it's so insidious, isn't it? This development of cognitive impairment that even when you've known a patient for a long time, you can miss it, this gradual slide that they might have in their executive function and their ability to manage multiple chronic conditions.
It's true. It's easy to miss without doing really detailed and comprehensive evaluation for it. And I would add to that, we can miss reversible conditions, and that you'd hate to do. You'd hate to see someone
Mhm.
who's having some slow but steady changes at a point where if you do an assessment, you can intervene and stop it, even reverse it. But wait too long, the damage is done. To me,
Yes.
a perfect example would be something like normal pressure hydrocephalus. The
Mm.
earlier you identify it, you can intervene and stop it
Yes.
in its tracks, even reverse it. If you wait beyond a certain point, you really can't reverse the damage. And it's tragic to see someone who did not get intervention that can make all the difference.
Let's talk a bit about treatment. I mean, for many years, clinicians like myself have been used to prescribing cholinesterase inhibitors and NMDA antagonists, to reduce the symptoms of Alzheimer's. Of course, we realize it's not curative, but now we have the exciting advent of biological agents, which are largely focused on anti-amyloid therapy. Can you talk a bit
Yes.
about that? And I know a new drug has recently been approved.
Sure. So until recently, going back about 30 years, we've had what we call cognitive enhancing medications. And in all those years, there's only four of them that have been approved by the FDA. Three of them are in the same category, as you mentioned, acetylcholinesterase inhibitors, which essentially prevent the breakdown of acetylcholine. That's our main learning and memory neurotransmitter. When you have more in the brain, people tend to have a modest symptomatic benefit. You're not slowing the disease down. There's certainly not a cure. And for a lot of people, you can't even see much of a difference, but it's the best we have.
I
And then
agree.
we have memantine, which is a glutamate receptor antagonist, and it helps to decrease a form of glutamate overactivity, which we know is associated with neurodegeneration. So again, even combining an acetylcholinesterase inhibitor with memantine, at best you're getting a modest effect across different stages of this disease. So the search has always been for something to actually target the disease itself, to slow it down. I've been involved in clinical research for 25 years. A colleague of mine a number of years ago published a paper stating that about 99% of studies had failed. And unfortunately, the track record is not good. But
Yeah.
we've had good news the past couple of years. What you mentioned is that a number of anti-amyloid immunotherapies have passed muster with the FDA. Lecanemab is currently FDA approved, and it's been on the market the past 6 months, and increasing number of individuals are receiving it. It's basically regular infusions of anti-amyloid antibodies, and so it helps the brain's immune cells essentially dissolve amyloid plaque from the brain. And in clinical research studies, we also have anti-tau immunotherapy, although nothing that's come to the market yet.
Yes.
And the FDA just last week approved donanemab, which is another anti-amyloid immunotherapy. I've been part of the research studies for the past at least 10 years on all these immunotherapies. And I'd say the following, the data shows that in early stage disease, we can slow the course on average by about 30%. So we're not curing individuals. We're not making them better. That needs to be understood. but we are slowing the course. There are potential side effects that we can talk about, but this is a game changer for people who are in very early stages, because even slowing it by 30% gives them many more years of normality in terms of their daily life, and that's a big deal.
And also providing some more quality time for caregivers, time for decision making, time to have a meaningful life as people get older.
Very true. Very true. And that's important because this is not a disease that unfolds over just a few months. This unfolds over years, if not decades. And so by slowing it even further, as you mentioned, it gives individuals and their families more time to really plan and to build the sort of lifestyle that's giving them meaning and joy and
Yes. Yeah.
and in the face of these changes.
So, at what point in a patient that you see would you decide to offer them such a therapy, the anti amyloid therapies? What kind of clinical point in their trajectory?
Well, the data only supports the benefit of these treatments in early stage disease. And so we are looking for individuals who have very mild neurocognitive changes, but they have to have evidence of amyloid plaque in their brain. And there's only two ways to show that, either through a spinal tap by looking at cerebrospinal fluid or an amyloid-based PET scan. Currently, the plasma tests are not considered gold standards to
Yeah.
qualify for someone. So those are the basic requirements. And anyone in that stage, we talk about this treatment as a potential and look at their risk factors. And increasingly, people are taking advantage of it.
Is our health system, or maybe certain health systems, are we geared to the intensity of monitoring cognition, function, as well as neuroimaging? Are we geared to do this?
On a large scale, no. On a smaller scale, yes.
Yeah.
Now, as a memory disorder center, this is what we do every day. So we have it, down to, a well-oiled machine. But I would say for the most part, that's not the case. Insurance companies are lagging behind. Coverage for amyloid PET scans is still behind. I will tell you, just the mechanics of getting someone enrolled, getting the payment set up is really arduous. And part of the problem is that you're dealing with practices or centers that are often, since they're not based on procedures, funding and reimbursement can be quite modest. And so it's hard to build a program to do this on that basis. So, and I think as a result, many individuals who could and should be getting this treatment are not at this point. I do think that's going to change, but we still have a ways to go.
Right. And really, the most important question, even before that, is how do we begin to detect Alzheimer's disease early, right? Before, I believe there's studies going on in terms of screening older adults. I mean, should we be doing this like we screen for diabetes or hyperlipidemia?
Well, I'm of two minds. On the one hand, without question, a cognitive screen should be part of routine primary care beyond a certain age, without question. The difficulty is that it's a complex assessment and it's easy to misinterpret the results, to alarm people unnecessarily. I would liken it to, primary care offices may do regular cardiograms and just look for things in general. But once you have some issue, you're going to send someone to a cardiologist to,
Yes.
to really do the in-depth assessment. And that's really what needs to be done. And so when I do a lot of education with primary care clinicians, I always talk about, doing what you're able to interpret and close the loop with. And if not, let other people do that. So for instance, it's one thing to do a cognitive screen, but you have to be trained in it and you have to be able to explain and interpret the results to someone. If you can't do that, I don't recommend doing that. I mean, if any of us walked into, a primary care office and we were offered some sophisticated tests on genetic risk factors without counseling and explanation, it could really do
Yes.
as much harm as good. So
That's very true. And unfortunately, I think many patients do not see that their primary care clinicians can actually do some cognitive screening and a series of blood tests to look for reversible causes. And, so often there's a lot of frustration and people are searching for specialists before the patient has had a good basic evaluation. in terms of their chronic conditions and optimizing those conditions.
It's true. And that initial data is not very revealing. And so, for instance, when I've been involved in forensic cases and I've had to review detailed hospital records, I've seen individuals or reviewed individuals who have pretty significant neurocognitive changes. But when you look at the hospital records, you see this, alerts and oriented times three, as if
Correct.
that's the end all be all of their cognition. That tells us very, very little. That's like looking at someone saying, I think they're okay without, taking any vital signs.
And we even miss delirium sometimes in the hospital setting.
That's a perfect example of obvious things that can be missed. So it,
Yeah.
it does require more training, better instruments, but we have a shortage of geriatricians. What you do, what I do is still a rarity. And we don't have enough clinicians
Yes.
going into this field.
Mm.
And there's not as much motivation to get people to go into the field. And that has to change
Indeed.
because as the population is getting older and older, we need more and more specialists to deal with that.
I agree. Going back to the research, where do you think we are in terms of therapies that target tau protein accumulation?
Well, there have been a number of clinical trials. In fact, we've been involved in several of them, which have tried to either target tau directly or use immunotherapy to get rid of tau in the brain, just the same way we get rid of beta amyloid in the brain. And it's been, so far not as productive as hoped. So, in fact, we're just starting up with a new anti-tau immunotherapy. The goal has been to try to find out, what's the best location on this abnormal form of tau to target. We've had the
Yes.
same issue with amyloid. Beta amyloid is formed as these monomers, and then it becomes oligomers floating around the brain, and then fibrils floating around the brain, and then the fibrils are locked into the plaque. So,
Oh.
at what stage do you need to target this, and will
Mm.
that make a difference? And probably at the level of the fibril or the plaque is the most important area to target it. If you target it too early, it might not be as effective. And we're seeing somewhat of the same issue with tau right now. So I think we're a little ways off. But I can imagine what would really be effective would be combining anti-amyloid and anti-tau immunotherapies, because it's like putting out a fire when you have two different sources of the fire. You have
Yes.
two materials burning, and if you only put one of them out, you haven't really put out the fire.
And is it not true that most experts are, or some experts are not convinced that amyloid is the only problem in Alzheimer's disease?
Well, that raises another very important question. We have what we call the amyloid cascade hypothesis. And this is the basic belief that this formation of abnormal amyloid and its deposition is the cause of Alzheimer's disease. And so if you simply stop or interrupt that process, you will essentially cure the disorder. We know it's more complicated than that. Tau is involved. There's inflammation, there's changes in metabolism in the brain. What's the first process? What's the most important? Is it a matter of formation of beta amyloid or a matter of or clearance of it? These are things being investigated. So we do have a ways to go to fully understand it. And that's why, even though you can clear the brain of amyloid, you've not cured someone. In fact, you've not even
Yes.
made them better. It tells us that the story is much larger.
It's complicated. Yes.
Yes.
So, Dr. Agronin, one of the things that really interests me is the kind of care we provide to older adults in general, in a non-judgmental, non-ageistic format, and the effect of empathy. Can you talk a bit about that?
I've worked in long-term care my entire career. And one of the most exciting movements has been what's called person-centered care. Instead of basing care around the needs of the institution and getting certain things done, we turn to the person themselves, the individuals there, and think about what's best for them and how can we revolve care around them. So this has really brought a revolution in terms of improving long-term care. Now, as I've worked with this approach and thought about it a lot, I realized that it depends on knowing the person. You can't give person-centered care unless you really understand the person, and everyone's unique.
What is their story?
Everyone's story, you're right, is unique, and what's good for one person might not be good for another. So you could argue that something like pet therapy would be a wonderful person-centered care, but not everyone likes pets or feels comfortable with them. It could
Yes.
be the opposite for people. So how do you best understand someone's story, their life journey? It's by putting yourselves in their shoes and imagining what it's like for them and testing that out and getting to know them and asking them questions. This process is called empathy. And so I began working at Miami Jewish Health to develop a program which is empathy centered, to train staff to recognize what empathy is and how to improve theirs. And we call this EmpathiCare. And we're still working on developing it, but really a way of supplementing and enhancing person-centered care. That's what EmpathiCare is all about. And I think it brings, both for the person you're working with and for yourself, greater meaning and greater joy in what you do, because you form much closer and more informed
Yes.
connections with people and their families.
And I've also read that patients who feel their doctors or their clinicians are empathic are more likely to follow their recommendations or even discuss all their personal issues regarding their health. And also, conversely, doctors themselves who practice in a more empathic way tend to be more satisfied and experience less burnout. Personally, I find the second part to be very true.
Yes, this has always been my experience. You said the buzzword earlier, stories. I love learning about the stories of individuals, where they've come from. It goes way back to when I trained in the VA system. I'm a big World War II history buff, and so I like to hear from veterans what they did, where they were from, how they interacted with
Yes.
individuals. This is what really led me to do a lot of the writing I do, because I wanted to tell some of these stories and reflect upon them. And it began to change the way I looked at aging. What I realized is that as a physician working in geriatrics, you tend to focus on the downside of aging, because that's your calling, to diagnose disease and assess dementia and deal with death and dying. And yet along the way, when you listen to some stories, you also see the strengths that they have. And these are not strengths that are just residual. These are strengths they are developing and gaining despite what they're facing as they age. So this changed my entire perspective on aging. And I began to realize that if you're not looking at the strengths at the same time you're looking at the deficits, you're really missing half the story. And at the end of the day, it's the strengths that's going to carry the day. What is going to help someone cope with disease, with dying, with pain? It's going to be the strengths they have, their resilience, their creativity, the connections they have. And if you can find ways to identify those and bolster those and bring those out, it's part of the healing process as much as medications and other approaches that we do.
Yeah, I think this is so important, how we can encourage even our colleagues, clinicians, our learners to reframe their approach to the older adult, who is not a series of multiple medical problems or neuropsychiatric problems, but a source of actually a lot of wisdom, humor, history that we would never be part of if we did not get to know these people.
We need to think about ways to factor that into our current approaches. Electronic data records are notorious for just being a growing laundry list of problems. They don't talk at all about strengths, or they don't focus on the story and who the person is. You just become a
Yes.
series of data points. And the more we're focused on getting all those data points in, the less we're focused on the person. And I would just ask everyone to reflect upon this. Think about the last time a doctor actually laid hands on you and examined you. When you go into, whether it's an ER, an office, whatever, it's usually very quick. You're rarely touched in any way or even examined. It's just focus on what are the problems and what are the algorithms to deal with that. We lose the person within that.
And does the EHR get checked off in the appropriate places?
Often it doesn't, or so many things are added to it that it's hard to see the person amidst all the different data points.
So we have to teach people how to look at aging in terms of not a time for despair and waiting for death, especially advanced old age, but a time, as you said, to look at their strengths and to promote, as you've written one of your writings, to promote integrity versus despair.
Yes, this is something that it touches into the work of Eric Erickson, who talked about the
Yes.
stages of life. And what he and his wife wrote about in the last work is that, and we see this in our in individuals' lives, that when someone becomes overwhelmed by physical changes and issues and challenges, despair is often right there, because it's difficult and it's a process of loss. But people find ways to balance that, and we need to learn from how those individuals, how they do it, how they're still resilient, how they cope, because it's good lessons for all of us.
Yes, I had a patient a week or two ago who was so overwhelmed by her functional problems and financial issues etc. But when we talked to her and we're trying to use this 4M framework of age-friendly healthcare, I realized what mattered to her was that her grandchildren, nieces, and nephews knew where they came from. What was the story of the family and what was the legacy? And so I encouraged her to write about this, to leave something for the nephews and nieces. She said if they come to my funeral, they're not even going to know who each other is and why they're there and who we were as a family.
Yeah, the richness of the connections that people once had, I think has changed a lot. And I think care is so atomized today that, and people are so mobile today, we don't have the same roots and anchors that we once had. And I think that's a loss. By bringing this back into medicine in different ways, it just brings a richness to it. And ultimately, to me, this aids in people being healed as well. I'm convinced of that because when individuals have a better attitude towards aging, they have a greater sense of purpose and connection. It gives a benefit in terms of illness and a better benefit in terms of mortality. In fact, I would point to the work of the Yale psychologist Becca Levy, who's done a lot of work on attitudes towards aging, and has really remarkably shown in studies that those individuals who have a better attitude towards aging actually live longer. They have lower rates of dementia. People with higher sense of purpose and other studies have fewer heart attacks. This is extraordinary data, and yet we don't take advantage of this and integrate this into our approaches.
Incredible. So, your last word, if you had one magic wish in terms of Alzheimer's disease and geriatric mental health, in terms of research and clinical care, what would it be?
Well, we need a cure. Everything begins and ends with that. We're getting closer and closer to actually having a way to slow the disease, but we need to stop it in its tracks. This disease takes such a toll on us as individuals, on families, on society. It's the most expensive disease in the country. We need an effective treatment to really stop it. That would be a game changer. When you think about it, the average age of retirement is in the early 60s. But with lifespans today, it means we have another 20, 25, 30 years of living ahead of us. Unfortunately, too many people, a lot of that time is complicated by neurocognitive disease. If we can change that, it opens up an entire amazing landscape of aging that not only brings benefit for us, but benefit for younger people as well. So again, if we can cure Alzheimer's disease, or I should say, when we cure Alzheimer's disease, it will transform what it means to age.
Where can the audience find more resources on this topic, Dr. Agronin?
I think the Alzheimer's Association is probably the best resource when people want to learn more about risk factors and resources and whatnot. I always tell people to start with that. And there are also many local resources. So for instance, for those living in Florida, there's a network of memory disorder centers, which can be found online through the Department of Elder Affairs. We have 4 of them right here in South Florida. One of which is where I work, Mind Institute at Miami Jewish Health. And this is where individuals, if they need assessment or follow-up, can really get some of the best care, in addition to many other practices.
Thank you so much, Dr. Agronin. Thanks for joining us today and sharing your expertise with our audience. It's been a real pleasure having this discussion with you.
Thank you.
Please stay tuned for upcoming topics from our renowned subject matter experts.